Today I will be presenting a case report over complex ovarian mass in a second trimester pregnancy. This is April Riley and Hannah Coday with the Department of Obstetrics and Gynecology. Diagnosis of adnexal masses in pregnancy has increased over the past decade because of routine ultrasound screening for fetal anomalies. The management options include either observation or surgical intervention. However, there are risks involved with both. Risks of observation include malignancy progression, obstruction of labor, rupture, or ovarian torsion. However, the risk of surgical intervention can include infection, bleeding, damage to surrounding organs, and risk of anesthesia. Risk of surgical intervention can also include preterm contractions, preterm delivery, injury to the gravid uterus, or injury to the fetus. Ultrasound can be used to help categorize these masses into either complex or simple. However, these definitions can be somewhat misleading, as occasionally masses that are categorized as simple may be malignant, and those that are complex may actually be benign. The reported incidence of adnexal masses during pregnancy is 0.05 to 3.3%, and malignancy occurs in 3.6 to 6.8% of the women with persistent masses. Ovarian cancer is the fifth most common malignancy diagnosed during pregnancy, which comes after breast, thyroid, and Hodgkin's disease. In a hospital, discharge records were obtained and a 0.93% incidence of ovarian malignancy in pregnancy was found, which was one cancer per 56,000 deliveries. A total of 1.25% of these masses were borderline tumors. Our patient is a 20-year-old G1P0 who presented for prenatal care at 16 weeks by her last menstrual period. She had no complaints and no significant medical or surgical history. Her family history was significant for colon cancer in her mother, but with no family history of breast, uterine, or ovarian cancer. She denied any alcohol, drug, or tobacco use. And on physical exam, her uterus was consistent with a 16-week size and was otherwise unremarkable. At that time, an ultrasound was ordered for fetal anatomy and dating. This is a picture from the patient's ultrasound, which shows an adnexal mass with a papillary excrescence, which is noted by the arrow. And the placenta can also be seen in this same picture. This is another image from her ultrasound, which shows an ovarian complex cyst, which measured 7.4 centimeters by 5.8 centimeters by 6.7 centimeters. And again, the red arrow indicates the papillary excrescence, which is noted. On the right, some blood flow can be seen adjacent to the papillary excrescence on color Doppler. The cyst is otherwise fluid-filled with no septations. The patient was then scheduled for exploratory laparotomy for removal of this cyst. She underwent exploratory laparotomy, right oophorectomy, and pelvic washings at 22 weeks gestation without complication. At the time of her surgery, an ovarian mass with smooth borders and no extraovarian lesions or lymphadenopathy was seen. This shows a picture of the ovary, which was removed and measured 6 by 5 centimeters with smooth borders and was sent to pathology. This is an image of her staining, which shows borderline tumor with papillary and polypoid proliferation that does not extend to the serosal surface. She was found to have stage 1A borderline serous epithelial tumor. The serous borderline tumor is 4 centimeters in greatest dimension, confined to the intact right ovary without serosal involvement. The tumor was also negative for invasion. The parenchyma was uninvolved, and the pelvic washings were negative. Patient recovered from surgery well and went on to have an uncomplicated delivery at term. She is being followed in the oncology clinic at 6-month intervals and currently remains free of disease. Ovarian cancer in pregnancy luckily is rare. The physician relies on a combination of imaging, patient's history, physical exam, labs to inform a recommendation. The imperative step is to rule out ovarian cancer, which can have a very high mortality. The recent first international consensus report on adnexal masses management recommendations should help standardize the management of adnexal masses in the future. These guidelines have a set of simple rules to follow to help the provider determine if a mass is ovarian or malignant. The IOTA simple rules are comprised of 5 features that are indicative of malignant lesions, which are called M rules, and 5 features that are indicative of benign lesions, which they call B rules. If one or more M features apply in the absence of a B feature, the mass is then classified as malignant. If one or more B features apply in the absence of M features, the mass is classified as benign. If both M features and B features apply, or if no rule applies, then mass cannot be classified. The benign features are number 1, unilocular cyst, 2, presence of a solid component, which is less than 7 millimeters in largest diameter, 3, presence of acoustic shadowing, 4, smooth multilocular tumor with a largest diameter of less than 10 centimeters, 5, no detectable blood flow on Doppler examination. For malignant features, they include number 1, irregular solid tumor, number 2, presence of ascites, number 3, at least 4 papillary structures within a cystic lesion, number 4, irregular multilocular tumor with a largest diameter of 10 centimeters or greater, 5, very high color content on Doppler examination. In conclusion, masses during pregnancy can either be observed or surgically removed, and new recommendations have been put out to help guide the provider to determine the best treatment for the mass seen. Again, this is very important due to the high mortality rate with ovarian cancer in pregnancy and outside of pregnancy. And listed are my references. Thank you.